for joining us this afternoon. I'm Robert Sellers, Vice Provost for Equity and Inclusion and Chief Diversity Officer here at the University of Michigan. The University of Michigan has a long history of supporting scholarly inquiry into questions of diversity, equity, and inclusion. And the university's faculty over the years have made significant contributions through their expertise and commitments in these areas. In addition to scholarly engagement, U of M faculty have also contributed in transformative ways to inclusive teaching and mentoring, as well as impactful service and engagement. These efforts have provided greater access and greater opportunity towards higher education for many of our students. In 2019, the University of Michigan, as part of the DEI strategic plan, established the University Diversity and Social Transformation, or UDST, professorship to both honor and build upon our rich legacy of our faculty engagement, commitment, and achievement in DEI. These professorships are awarded to exceptional faculty who have throughout their careers demonstrated a commitment to the university's ideals of DEI through their scholarship, teaching, as well as their service and engagement. The UDSTP is reserved for only the highest level of achievement. A goal of the professorship is to shine a bright light on the many outstanding contributions that these remarkable faculty have made to our community and to our society. In addition to recognizing individual achievement in the area of DEI, these professorships are also designed to grow the university's capacity to do effective and impactful DEI work. UDST professors are granted special fellow and resident status in our National Center for Institutional Diversity, where they interact with other awardees, faculty fellows, postdoctoral scholars, and students. These residencies within NCID help create a community of scholars who have overlapping scholarly, pedagogical, and engagement interests that also stimulate exciting new collaborations and new synergies for which we all benefit. And this brings us to today's event. Today's event is part of a series of scholarly talks and presentations that showcase the transformational work and extraordinary contributions to DEI that is made by our university DSTPs. I'm particularly excited to participate in today's session, given the fact that I've known today's speaker, Marita Inglehart, for more than 35 years. And I've admired her commitment and generosity of spirit during all of this time. So now, without any further ado, I'd like to turn the program over to Professor Tabby Chavis, who is the director of the National Center for Institutional Diversity, as well as the Associate Dean for Diversity, Equity, and Inclusion in the College of Literature, Science, and Arts, and a professor of education and psychology. Professor Chavis will introduce our distinguished speaker and then moderate a Q&A session after the talk. I hope you enjoy yourself. Without any further ado, Professor Chavis.
Thank you, Rob. As a faculty member here at the U of M and director of the National Center for Institutional Diversity, or NCID, I'm thrilled that this professorship was created to honor and recognize exceptionally accomplished senior scholars who throughout their careers as faculty have made significant and innovative contributions to knowledge production and action. Each honored professor has created and led intellectually grounded and impactful practices, programs, and other efforts to enhance DEI in higher education, in their disciplines and fields, and in a variety of local, national, and global communities. NCID is so pleased and proud to be a point of connection and community for these scholars. Each year, NCID will host public lectures featuring the work of these esteemed colleagues to further elevate and honor their exceptional accomplishments. Today, I am thrilled and honored to introduce Dr. Marita Inglehart, University Diversity and Social Transformation Professor, Professor of Dentistry, and Adjunct Professor of Psychology. As a scholar, Professor Inglehart addresses the role of diversity in dental education and in oral health care settings. Her research has focused on both how to educate future healthcare providers to become culturally literate providers and on documenting how underserved patients' poor oral health affects their quality of life. She has published over 100 peer-reviewed publications, 5 books, and numerous book chapters. Professor Inglehart has sustained her diversity efforts for more than 30 years at the University of Michigan, with over 20 years at the School of Dentistry. Her leadership gave rise to diversity-related changes in the school, including advocating for students, staff, and faculty members from LGBTQ+ backgrounds. Further, she developed diversity-related orientation programs that received 2 Best New Program in Dental Education awards from the American Dental Education Association. Professor Inglehart is an exemplary leader and advocate for and scholar of diversity and inclusion at the University of Michigan and beyond. She enhances the success of students and faculty from diverse backgrounds, serves as an enthusiastic mentor to countless students, and through her research, teaching, and practice, continues to bring equity to our society. It is now with great pleasure that I turn the podium over to Professor Inglehart, whose talk is entitled Dental Care Providers and Patients from LGBTQ+ Backgrounds, Dental Education and Research Observations from 1994 to 2022. Marita.
Thank you very much, Tabby and Rob. Thank you very much for this introduction. I will now share my PowerPoint here and then get started. So this week is the Pride Week on campus, and I thought it's a wonderful time to talk with you about dental care providers and patients from LGBTQ+ background and tell you a little bit from the time in 1994 that I got really interested and very motivated to look at this topic to what we are doing today. When I talk about this, then I have to acknowledge all my former students and my colleagues who collaborated with me on the research with great appreciation for their contributions. All the way back, Jason Seacat, Joan, April, Dr. Temple, Ken Hillenberg, all my colleagues here, and now Dr. Schwartz from the University of Cincinnati. This work that I'm talking about was very much inspired and encouraged by Jim Toy, and I really want to thank him for that. So I want to start you out by talking about why I was interested in talking with you about this topic, provide some definitions and prevalence data to show what this is all about. And then I want to talk about the importance of considering research, education, and clinical care when we talk about this topic. In 1994, I was very fortunate that we had some amazing leadership in the dental school, a dean who was very much involved in covering partner rights for employees from LGBTQ+ background. Also, Dr. Lisa Tedesco, wonderful, wonderful academic dean, and Dean Kadowitz. And they started a first ever cultural audit at the University of Michigan School of Dentistry when, as far as I remember, no other unit at the university did a cultural audit. And I was very happy to co-chair that audit. And it was a wonderful experience. Now, we did surveys with staff, students, and faculty, and only 6 respondents self-identified as homosexual and 6 as bisexual, but 48 persons refused to answer. And the answers that everybody gave about what they perceived, observed as a climate towards people with different sexual orientations were so striking that we decided we would follow up with focus groups with just persons who self-identified as homosexual or bisexual, and they could meet outside the building, led by an external person who had nothing to do with the dental school, so they were assured that everything was completely private. The audio tape was transcribed, and every identifying information was removed. And then it came back, and was perhaps one of the hardest things for me to ever write, because it was eye-opening for me what was happening at that time. So the fact that we had this survey and then decided to do a follow-up focus group with one particular social identity group was actually, interestingly, also the case in the first ever nationwide US veterinarian schools. And I found that very interesting that even in 2014, when they did a nationwide survey, their results in the surveys about student, staff, and faculty from LGBTQ plus background were so striking that they also decided they needed focus groups to understand what's really going on. Now, in 1997, we followed the recommendations, and I taught a class that asked the students to learn about patients from different backgrounds. And before the class, I asked them how interested they were in learning about treating children, patients with mental health disorders, and so on. And the answers went from 1 not at all to 3 very much. And what you see is when you look at the importance rating, the most important to the least important, that the patients with different sexual orientations were rated as this, learning about this topic is the least important of all topics. And of course, at that time in the 1990s, we pretty much focused on sexual orientation, and my awareness of gender identity issues was very minimal. And now when I look at sexual orientation, I must say my understanding of sexual orientation was also very limited, because as Liz Gonzalez pointed out in an ally workshop she gave, there's an article that talks about 27 different sexual orientations. And so think back to 1990s and remember how limited we were. I also want to add a slide or two about definitions of puberty blockers, because they are politically such a highly discussed and misunderstood topic. And I want to point out that puberty blockers prevent the development of secondary sexual characteristics. They are usually initiated between 18 and 30 years of age, and they are completely reversible. So the idea that these 8 to 13-year-olds, when they start on puberty blockers, that something would happen that is not reversible is absolutely wrong. Puberty blockers can be given as injections, and those last 1, 3, or 4 months. They can also be given as a rod under the skin on an arm, and that would work for a year. In order to block testosterone, some of the children and adolescents also get anti-androgens, and they are all, this whole medication is always given in connection with counseling and supervised by endocrinologists. Now, one interesting question is being interested in LGBTQ plus issues in healthcare an issue that has a high prevalence, or is it something that rarely occurs? And in January 2022, the newest Gallup survey showed that at that point, 7.1% of the adult US population actually self-identified as LGBT. And what was really interesting in this published study in 2020 was that when you look at the Gen Z group, which are born between 1997 and 2012, and you look at the adults, 1 in 5 of this youngest cohort identified as LGBT. When you look at pediatric patients, then the Centers for Disease Control did a study in 2016 with high school students and found that 8% self-identified as LGB. And in 2017, in the CDC's Prevention's Youth Risk Behavior Survey, they could show that 1.8% identified as transgender. And when I remember our campus-wide survey that was taking place before COVID, a little while before, I think we had 1.8% of college students and 1.6% of graduate students who identified as transgender on our campus at that time. So now let me tell you what I really am passionate about and really believe, and that is that we need to look at research, LGBTQ plus related oral health and oral health care research. There's too little and we need more. We need to look at LGBTQ plus related education. Professional education of future dentists, of current dentists, is crucial. Every healthcare provider needs to be better educated about this topic. And we need to gain a better understanding of LGBTQ plus related patient care. And I think only when we try to get those three things interconnected will we make any progress with reducing health inequities among the LGBTQ plus community. So let's start with the research and start with the medical research, which is far ahead of the oral health related research. And one monumental and influential report was the March 31, 2011 released consensus report on the health of lesbian, gay, bisexual, and transgender people. And the 17 scientists who wrote this consensus report did a wonderful job. They categorized the information, they looked at all the research that was there, and they thought there was very little research, but actually when you look at it for 2011, it was very rewarding that there was quite some research at that time already around. They categorized it by age group, so they had one part of the report on childhood adolescence, one part on early middle adulthood, and one on later adulthood. And for each of these three categories, they talked about in that part of life, what's the development of sexual orientation and gender identity? How does it affect mental health? How does it affect physical health? Which are risk factors that work against having good health and protective factors? How about health services and contextual environmental influences? And this report was just phenomenal at the time. It showed clearly that the healthcare utilization is lower and that persons who self-identify as part of the LGBTQ plus community have risk factors for poor oral health, especially higher substance use. When you think about Michigan, where 19% of adults use tobacco, here you see it's 25 to 30%. And that's a horrifically bad thing for oral health to use tobacco. When you look at mental health, again, you see that members of the LGBTQ plus community, unfortunately, are 3 times more likely to experience depression, anxiety, or other mental health conditions. And then when you look at suicide, the suicide rate is much higher. And especially when we think about LGBT youth, then that is a very sad situation. In addition, we have quite a number of consequences of homophobia and transphobia in healthcare settings. And 8% of the LGBT self-identified adults and 27% of transgender individuals reported in 2010 in a Lambda Legal survey that they were refused medical care at least once. When you look at the negative interactions, you see the same trend always, that LGBT 10% and trans respondents more likely, for example, to experience harsh language towards them, or that health professionals refused to touch them or used excessive precautions like double gloving or things like that. And very sad that 12% of LGBT and 20% of trans respondents reported being blamed for their health status. Another very critical kind of consequence of homophobia and transphobia is that doctors were underinformed, and that half of the trans individuals reported that they had to teach their medical providers the very basics about transgender care. And the last bullet point is very sad, because you see that respondents reported when they were sick or when they were injured, 28% postponed medical care because they were afraid of discrimination, and 48% were unable to afford it. So how about the oral health related research? What do we have there? In the year 2000, a milestone in oral health research occurred when the first ever US Surgeon General report on oral health was published. This report had a tremendous effect because it showed that in the US, persons from socioeconomically disadvantaged background, from underrepresented minorities, persons with different abilities, all had significantly poorer health than others, and had tremendous problems accessing oral health care. For the follow-up, next US Surgeon General report on oral health that was supposed to be published in 2020, but because of COVID did not get published until 2021, and then only as a report by NIDCR, Scott Schwartz and I were asked to look at the research and help to inform this new report about oral health related issues for persons from LGBTQ plus backgrounds. And we started out to look at the first report, and then I got pretty shocked, because in the 332 pages were 6 sentences where heterosexual versus homosexual orientation was mentioned. And it was always mentioned with, and then there are other persons such as homeless and prisoners and people from LGBTQ plus backgrounds. And that was very painful to see. In the new report, there's more material now, and not enough, as Scott and I think, but at least there was some way to get more information into this report. In 2018, Scott Schwartz published a great article where he used the National Hands-on Nutrition Examination Survey that the Centers for Disease Control does, which is a wonderful, wonderful survey where they look at survey data plus exam data. And so they did a wonderful set of oral exams in several of these waves. And he reported that while oral health exams showed no differences between gay, bisexual, and heterosexual adults, bisexual adults were more likely to rate their oral health unfavorably, and gay men reported more bone loss around the teeth than heterosexual and bisexual men. This was the first and up to that point only publication, as far as I know, about oral health of gay and bisexual adults in the US made with actual oral health exams. In 1999 to 2016, when all these data were there, Alexandra Horner, Michelle Young, and we looked at these data together with Michael Mans, and we found several interesting things when we compared the data from gay, lesbian versus bisexual versus heterosexual self-identified respondents. First of all, look at the high percentage of persons who self-identify as bisexual who say that their mouth feels dry when they eat and that they sip liquids to aid swallowing food. Having a dry mouth is a very bad thing for oral health because it sets you up for more cavities, it sets you up for more oral disease because the saliva serves a wonderful service to wash away bacteria that could cause oral disease. We also looked at the responses related to periodontal disease. And here we found when people rated the health of their teeth and gums on a 5-point scale that overall, and 5 was excellent, sorry, 1 was poor, that overall gay and lesbian respondents reported that they had poorer oral health, and they also reported more bone loss around the teeth, as Scott had also showed. We also looked at risk factors, and we could find that in these NHANE data for the 17 years, there were definitely differential illicit drug use behaviors between the 3 groups. In addition, there are 4 studies in the US in 4 different states that looked at the oral healthcare services for persons from LGBT background. In Ohio, they found that only 10% of LGBT adults reported regular dental visits. And I think that is really amazing when you think about only 1 in 10 adults from LGBTQ backgrounds have regular dental visits. Cost and fear was 1 point, and that's a point for many US citizens or adults in the US, but 8% had experienced discrimination and did not want to go back. Now look in Colorado, here you find something really wonderful because they asked the respondents if they had an LGBT friendly provider. And when the respondents that identified as being from an LGBT background had a friendly provider, 61% had seen a dentist in the past 6 months. That is more than the general population for 6 months. Now, again, in Hawaii, they only asked for LGB, not for LGBT responses. And they again found that persons from LGBT backgrounds had not visited a dentist to a larger degree than persons from non-LGBT backgrounds. And the same thing happened in Wisconsin. And so when you look at this research, that lack of research might explain why we had very, very little education about treating patients from LGBTQ plus backgrounds in dental schools. So when we did a survey in 2009, we sent it to dental student leaders in all the dental schools. And we found that only 13% of dental student leaders said that their education had prepared them well for treating patients from LGBT background. When you look here, these 2 questions, my classes prepared me well, only 10% agreed and 3.3% agreed strongly. Now look at the next row, because this is important. Do these students agree that their curriculum should include more education about treating patients from non-heterosexual background? And you see, that's not the case. Actually, over half of them disagree strongly that the curriculum should include more information. Now, in 2016, we did a study with the US dental school administrators and the program directors of the dental hygiene programs in the US. We have 78 dental schools. We had at the time 365 dental hygiene programs. And each of these leadership top administrators received a survey asking them what they taught in their curricula about LGBTQ plus content. And you could see that only 52% of the dental hygiene programs covered any LGBTQ plus background, and only 71% of dental schools covered any LGBTQ plus background. So when you look here, we were very interested in what kind of background they covered. And you see that the number one topic of these programs that did cover, not overall, but just the programs that covered, was HIV and sexually transmitted infections in LGBT people. And in many schools, that was the only topic that they actually talked about with their students. When you go down, you see oral health disease risk, 63%, 54%. But then when you go further down into transitioning, body image in LGBT people, which is a huge issue because it can lead to eating disorders, disordered eating, and that is a disaster for oral health. And then you see safer sex for LGBT people and sex reassignment surgery. You see that pretty much just like 1 in 10 of the schools that taught about it actually talked about these issues. So how about in 2016 to now? Are dental students more interested to learn about these topics? Remember, I showed you from 1997 when I did the survey the first time. And now I combine the 2016 to the 2021 data. And unfortunately, when you look, we have exactly the same results. It was 211 in 1997. And now the interest is still the lowest for patients with different sexual orientations, transgender patients, and women and gender issues. Women actually, unfortunately, despite increasing research about gender differences in oral health, still the interest of our students to learn about it here at the University of Michigan before they take the class is really, really the lowest of all different topics that are covered in this class. How about in 2021? We sent a survey out last year for general dentists, members of the American Dental Association, Scott Schwartz and I. And when we got the data back, it was very clear that this dental school education did not prepare these general dentists well, not in a classroom setting, not in a clinical setting, which would be really important, and not in a community-based education setting where our students go and where dental students all over the US go to get community-based education and be exposed to different populations. And when you look here, 1 is disagree strongly and 2 is disagree, you see that over 50% said that their dental school education did not prepare them well. And I think that's very, very important. About 3/4 say that their national organization does not, or their local professional network does not prepare them well, and that they had not participated in any continuing education courses about patients from LGBTQ+ backgrounds. How about pediatric patients? In 2020, Dr. Schwartz and I sent out a survey to members of the American Academy of Pediatric Dentists. And we got 382 surveys back, and we thought that especially a pediatric residency program would prepare them well about treating pediatric patients from LGBTQ+ backgrounds. But you can see the data pretty much for the dental school education are even worse than the ones for general dentists. And you see that even in the pediatric dentistry programs, the majority said that disagreed that they had been well educated in classroom-based settings, clinical settings, community-based settings. And again, you know, nearly half said that the AAPD had not educated them well about patients from LGBTQ+ backgrounds. You see a little bit higher percentage, just a tiny bit about CE courses, but overall, you can see that it's pretty low. And what that low education does is, it does not prepare them for patients in their chair that are, for example, on puberty blocker. Because here you see that about half of them disagreed strongly or disagreed that they were well educated about puberty blockers. And only 6.6% agreed strongly and 16.4% agreed that they were well educated. And so this is definitely taking a toll on these healthcare providers' knowledge. Now, this lack of interest of our students and this lack of education of our current dental healthcare providers is a huge problem. By now, we did 10 different studies with general dentists, dental hygienists, endodontists, orthodontists, periodontists, pediatric dentists, hospital dentists, dental hygiene students. And in every single one of the study, we wondered if their education about treating persons from socioeconomically disadvantaged backgrounds, or patients covered by Medicaid, or patients from ethnic racial backgrounds different from their own background, or patients with different ability levels. In each of these studies, we asked this whole set of questions about education about different patient groups with different social identities. And in each single study, we found something that is absolutely wonderful for any kind of educators. Namely, we found the power of professional education. We found in each of these studies that the better educated these providers were about treating patients from historically marginalized backgrounds, the more likely they were to treat these patients, the more comfortable they were to treat these patients, the more likely they were to set up their practices so that they are optimally set up to treat these patients, the more their staff was comfortable. It was a whole range of professional behavior and professional attitudes that was just absolutely wonderful to see. And so when you think about professional education and the professional attitudes and behavior that we as educators kind of try to shape, you see that we have a wonderful opportunity if we raise awareness in our current students and in our current dentists, wonderful if we raise awareness about issues, if we give them the skill to actually act on this awareness, because then only then are they committed. If they are just aware, they are not committed. They are just not able to figure out what to do. They're uncomfortable interacting with the patient. So we need to do skills training and the knowledge. And only when they have the knowledge and the skills do they really have the expertise. And with the knowledge and the awareness comes a deep understanding that feeds into that commitment. And so I came up with this humanistic model of professional education as my guideline of what I want to do in every class with my students, make sure that they become more aware of an issue, that they develop very concrete skills, and that they get the knowledge about it. So do dentists actually see patients who self-identify as part of the LGBTQ plus community, or would they not even see it? And this gets now to the third part in this triad of research, education, and care, and that's the clinical care. Do dentists engage in affirmative care? Not just tolerant, but affirmative care for all of their patients, including patients from the LGBTQ plus community. For example, do they collect additional information that allows them to treat the patients in a way that is best suited to them? You want to collect all the information about every patient that helps you doing a good job. How about, do they offer special accommodations? Do they, for example, communicate on their website that they have a practice where they do not discriminate based on all the social characteristics, including sexual orientation and gender identity? Do they have a statement like that on their website so that patients know what to expect? In the study that Scott Schwartz and I did in 2020 with the pediatric dentists, we were amazed by the numbers that we found. When we asked, do you have pediatric patients from LGBT backgrounds? Look, 86.8% said yes. And when we asked how many, all the 382, how many do you have? The mean was 5.9 pediatric patients on average. Then we asked, do you have pediatric patients who are transgender? And now the general public might think, well, that is a 1 in a million kids who would be like that. But here you see that 65.8% of these pediatric dentists said, yes, we do have in our practice children who are transgender. And it was very interesting because they would describe that sometimes the parents call them up before and want to talk with them and say, my child is transitioning from the gender assigned at birth, which was this, to the opposite gender, and changed the name. And on the insurance, it's still the old name. So the legal name is this, but please talk to my child by addressing my child with this new name and not the dead name for them that they have. And here's something I want you to look at. This was not just one among all, but it was 2.05 children who were transgender in these practices. And I want to keep something in, I want to put something out here too, that the literature shows that children who identify as transgender and would like to transition, only 1 in 5, one child out of 5 who wants to do that, gets the support of the family. And so when you realize that these are children who are, you know, have the support of the family, mostly, then this is an amazing kind of situation. Who are on puberty blockers? Do the pediatric dentists have any patients on puberty blockers? And yes, I want you to realize that 23.9% say, yes, I have a patient on puberty blockers. And among all the 382, on average, there were 0.6 children on puberty blockers. Now, when we hear of lawsuits that forbid treating children on puberty blockers, we might think that this is just an issue for 1 in 100,000, but this is not the case. And I think it's these data really show that healthcare providers have to be prepared to see patients from the LGBTQ plus community in these days. So how about collecting additional information? This is so crucial for every healthcare provider, that they have all the information to treat somebody safely. And so when we look here, we know that patients from LGBTQ plus background have certain risk factors, like increased smoking, increased alcohol abuse, other things. And so you see that a very small percentage actually asks for additional information related to these risk factors or in general. You see that here the patients who are on puberty blockers are more likely to ask additional information, while patients with different sexual orientations or who self-identify as transgender, it's only about 15%, 19%. Let's get concrete. Does your dental medical history form ask for the patient's sex assigned at birth? Ask for the patient's gender identity. Ask for pronouns the patient wants to have used, or provides a space to write in a chosen name. Now that provides a space to write in a chosen name is very high, but it's very high because pediatric dentists like to know if the child has a nickname or a preferred name that the family kind of uses for them, an abbreviation of their official name. And so that might explain this high percentage. We should have asked the question at the time, do you communicate your own pronouns on emails, on Zoom, and so on? Because that alone already could set the tone and could show that people are sensitive to these issues and affirmative to their patients potentially. I put a client registration form in here, and you see the Fenway Health Center in Boston is a LGBTQ plus specialized health center, and they ask for legal sex and explain that it is because health insurance might need it. But they also asked for preferred name, preferred pronouns, and so on. Does your medical dental history form ask about risky behavior? We know that 14 to 18-year-old high school students who self-identified as LGBTQ plus had a higher level of use of cigarettes, marijuana, alcohol, were about 10 times more likely to use methamphetamines, which is a horrifically bad thing for oral health, and 3 times more likely to misuse opioids at a time where many of them will have their third molars, their wisdom teeth removed, and might get opioids, unfortunately, when they had that done. We also know that there is more sexual behavior, and we all know that HPV viruses cause oral cancer. And so being prepared to talk with children about that is important. And disordered eating is a big issue, much more. We know that gay men, in comparison to straight men, have a higher percentage of eating disorders and disordered eatings, and that lesbian women, in comparison to non-lesbian women, have a lower degree of disordered eating and eating disorders. And so being very tuned in, because dentists are usually the first ones who will identify symptoms of eating disorders, being very cued in to really be aware that this is the case is crucial. Spatial accommodations. We think that staff training is really important. And so did they provide training for their staff so that the staff has adequate training concerning treating patients from LGBTQ plus backgrounds? Is the staff comfortable? And you see in the majority of the questions, when we broke it down by sexual orientation, transgender, diverse transgender, and puberty blockers, we have always the same trend that LGB is more positive than transgender or gender diverse, and the lowest positive responses we got on puberty blockers. Does your website communicate that you are accepting of gender diverse trans patients and their families, or patients from LGBT backgrounds? Do your patients have access to gender neutral bathrooms? The percentage there is so high because many solo practices still have only one bathroom. But in summary, we are all aware that health inequities are a huge problem in the US. If we want to overcome it, we need to take a comprehensive approach. We cannot just focus on research, but we have to make sure that we have the research connected with educational efforts and with clinical care efforts, and consider the interaction between these three components. Basic and public health research needs to provide the basis for sound educational efforts. And only when we do sound education for our current dentists and for our future dentists, our students that we see every day, and dental care, health hygienists and other dental care providers, the more likely they are to treat and be comfortable treating underserved patients. And the basic and public health research must provide the empirical evidence for evidence-based care. Health inequities and patients from LGBTQ plus backgrounds. Health inequities are a special problem, both for pediatric patients and adult patients who self-identify as members of the LGBTQ plus community. In 2016, an article was published that made me extremely happy. It took over 4 million implicit bias tests at the famous Harvard-based website where people can do implicit bias testing. And they looked at only adults from the US data. I think it was children over 13 or respondents over 13 years of age, and only in the US. And they looked at these 4.4 million data. If the LGB related implicit bias data showed any change for the last 8 years. And it was fantastic because it showed that implicit biases against members of the LGB community became more positive. And that was an absolute fantastic finding. But the current political climate in many states in the US results in increasing numbers of lawsuits and laws put in place against especially persons who self-identify as gender diverse. This public attention will affect the implicit biases that children and adults in the US have against members of the LGBTQ community, including the implicit biases that healthcare providers have, future and current healthcare providers. The damage that these lawsuits inflict on a personal level, an interpersonal level, with bullying, for example, in schools, and societal level cannot be underestimated. And these effects will play out in all healthcare settings as well. There's no doubt. Research, education, and clinical care, and the comprehensive analysis of the interaction is needed now for the LGBTQ+ community. I want to thank everybody who got me to this point in my life, and above all to our university, who provided the environment for student, staff, and faculty from LGBTQ+ background for a very long time. Was the first university who had an office for the LGBTQ+ community, and that allowed me to do this research and benefit from the tremendous knowledge of persons like Jim Toy. And now I hope we have time for questions.
Thank you, Dr. Inglehart, for heartfelt and such an informative and timely, and unfortunately and fortunately timely discussion and sharing of knowledge and wisdom. Thank you for the work that you've been doing and that you continue to do in this space. I'm eager to jump in with some of the questions that have been offered, as throughout the course of your talk and discussion. And I'll start with one that is about how dentists, how can dentists make their practice more accessible to people from LGBTQ+ backgrounds? And this particular question was, how can they proactively signal their acceptance? So there's education, but are there ways or examples or exemplars of how healthcare providers in this space can proactively signal welcoming and lack of stigma in this space?
Yeah, that is a very important question. I showed you the Fenway intake form. And when you think of it, it explains we only ask for your legal name because the insurance needs it. But what is your preferred name? What are your pronouns? That's the first thing that patients do. They fill out the intake form. Now, even before they get the intake form, my experience is that patients talk with each other about the dentist before they go to a new dentist. They don't randomly, pick a dentist. And having a website that signals very clearly that there's no discrimination based on sexual orientation or gender identity, among all the other things, is exceptionally helpful, I think. Because when I see that, that puts my mind at ease for family members from the LGBTQ+ community that I have. And so that is something that I would start with to get patients from this background into my clinic. One dentist said to me, I don't want to have an LGBT flag hanging out, a rainbow flag hanging out. This can be very subtle because both the parents of pediatric patients and adult patients, they look for cues. And so if they get these cues from the website, that would be great. Also, if you have any reading materials lying around, you could signal things with that. But I think the next step is once the patient sets foot in the practice, everybody, the staff has to be trained that they don't use the dead name of a person if that person transitioned, but to always use the correct pronouns and to use the correct preferred name. And, this is very tricky sometimes when patients might tell, pediatric patients might tell a provider, but that, or when our students actually tell in some circumstances that they are non-binary. But then we have to be very, very careful that we always check back with the students before we write, for example, a letter of recommendation or talk with other professors about them. And so, this confidentiality of information shared is very important to always consider in these circumstances too. So asking an adolescent now, when we call your parent in, is it okay that I talk with, I refer to you with your name? So that's always very important. So, it's not just dentist, it's the whole practice that has to be kind of embracing to understand the whole situation.
Thank you. I guess one of the questions that came from the audience is about the current status of the training for culturally confident care of LGBTQ plus patients, as a requirement for graduation in dental schools, kind of where you see the status now and the direction. And the attendee also wondered about, where we are here at U of M in that space.
Mm-hmm. I can only talk about the dental school. And since 1996, we have in one class talked a lot about treating patients from diverse backgrounds, including LGBTQ+. Now, is it enough to do it classroom-based once? No, absolutely not. And so we have monthly CE courses for 10, we try to do it 10 times a month, 10 times a year, free CE credit for all staff and faculty. And I always try, I organize these, and I always try to have at least one or two where we have this topic. For example, yesterday we gave one on respectful use of pronouns. And so what we try to do is we try not only to increase the curricular content, but also to offer continuing education free of charge about these topics, because we want to educate the educators about it. Every year we have the wonderful benefit of the Spectrum Center, and we have an ally training for our student, staff, and faculty. So in our school, we are very fortunate that we have a very supportive dean. We have a wonderful DEI assistant dean. Quite a while ago, actually in the early 2000s, students came and said they wanted to have a LGBTQ group. And so at that time, we met outside of the school because we didn't dare to do it in the school. Now we have the Alliance for Inclusion, and it's not as active as I wish it were, but it's as active as the students want it to be. And so I think creating a whole environment in our school, we try. Is it optimal? I'm not sure, but we definitely try. The other thing is it CODA required, the Commission of Dental Accreditation? Do they require LGBTQ+? No, they don't. What they do require in one standard is that the graduates has to be competent in providing care for patients from diverse backgrounds. So that's very general. It's only one of the many standards, but at least it's there and you can have it under that background. Is it optimal for our patients right now? I hope we are changing our intakes form, our axiom system, the computerized intake, and make space for pronouns and other things, but we will see. I know only of one dental school in the country that did it already, but I think there's a strong LGBTQ section of the American Dental Education Association, and I hope that the change will come for the patients too in our school.
Thank you. There are a number of audience members who are, intrigued and, educated on links between LGBTQ plus health, particularly those of transgender youth, and oral health. So connections that people might not have made before, and also how oral health relates to a variety of health outcomes that people often don't link. There are a cluster of questions around, think of clarification around puberty blockers and the link between puberty blockers and oral health for the youth, and in terms of what healthcare providers might do or know if they understand the impacts of puberty blockers.
Yeah, so puberty blockers is a hot topic. And when you think about transitioning, and you know that the depression rate and the suicide ideation rate is so much higher in LGBTQ plus young people, then it has to be made clear that, for example, depression has a horrendously negative effect on oral health. Oral health is not only related to general health, like, periodontal disease and diabetes go hand in hand. During pregnancy, if a pregnant patient, now that we have trans men who are pregnant, we have to say pregnant patients. When a pregnant patient has periodontal disease, the chance for lower birth weight, miscarriage in the second, third trimester, you name it, early preterm delivery for the baby goes up. So there is huge evidence of the relationship between oral health and general health. For example, the newest data on dementia and periodontitis is just striking. So I think more and more the public becomes aware of how important it is to have good oral health for cardiovascular disease, for pregnancy outcomes, for you name it. Now, what we don't have much yet, and even in this newest 2021 NIDCR Oral Health in America report, is all the many ways in which mental health is related with oral health. Eating disorders, yep. Bulimia, okay. You throw up, acid, lingual sites, the inner sites of your upper teeth will show it, all that stuff. Everybody might consider that. What people don't realize is that when these young people are depressed, even when they're not on medication, their saliva flow goes down because the depression does that to the body. Their eating habits become worse, and you name it. And so their motivation, we know the more depressed people are, the less they brush, the less they floss, the less they visit the dentist, and so on and so on. Now, if you know as a dental care provider that when a pediatric patient or an adult patient identifies that the risk for poor oral health due to smoking, in one study they showed that 75% of severe periodontitis is found in smokers, for example, in cigarette smokers. When you know that, then you can help these patients with fluoride treatments, with all kinds of more regular teeth cleanings. You can do so much more. With puberty blockers, we know one thing that is wonderful, and that is that if children who want to transition are on puberty blockers, the rate of depression, the mental health improves significantly, is completely different from the children who want to transition and do not have the availability of puberty blockers. So we know that in the population of children who take puberty blockers, the suicide rate, the suicidal ideation, the depression, all the mental health issues, it's definitely clearly a positive outcome. We also know that bone mass development might be a problem, which is not a problem for the development of the teeth because the teeth are already kind of there, but it is a problem for the bone in which the teeth sit. And more is needed, more understanding of how the long-term outcome of that might be and what can be done with endocrinologists to really help that is not an issue. So I think we're just at this point starting to understand more the oral health related issues that are coming up. But as a good dentist, as a good dental hygienist, you never treat the mouse, you treat the person, you treat the whole patient. And you see how the oral health is connected to the general health and to the mental health. And that is crucial.
Thank you. Thank you. You referenced that, you mentioned a couple of times, you used the phrase, what we are just starting to know, what we're just starting to know, what we need to know. A couple of questions related to this, the question of research and the lack of research specifically that impact education and clinical care. What are your views about encouraging more research in this area and addressing the barriers to this type of research?
Yeah, this is a very important question. I tell you, my own kind of opportunity to learn is always at the GLAMA meeting, the Gay Lesbian Medical Association meeting, because in this Gay Lesbian Medical Association meeting, which is once a year, you can get so much information about medical issues that I never get at any oral health conferences. At oral health conferences, it looks sometimes as if, especially international, because internationally, it's not as great for members of the LGBTQ community in every country. And so, especially in international meetings, I see, last year we had both Scott presented one part of the data, I presented another, but I was looking, I could not find any other LGBT related oral health research. And so, but in educational settings, I have more the sense that I find people I can talk with on oral health conferences, definitely. Like a DIA meeting, definitely. But in others, even when there is a diversity section, it's very low. And I'm not sure. I tried to talk with basic scientists who do bone-related research, but they don't see that they could get, for example, NIDCR grant money for doing a study of that. And I think partly it is because they think, well, these people are not around. How many people are on puberty blockers? We never have enough people to study, but that's not true. There is NIH research for pediatric patients who transition with 3 main centers in Boston, in Chicago, and in California, and they do that. And so there must be some way to also get money for that. But, right now I'm very grateful for the money I got from the University Diversity and Social Transformation Professorship because it funded 3 surveys for us. And right now I just do the first survey that I try to do with interviews with trans adults in Michigan. And that money that you give me there. I really appreciate it tremendously because it makes it possible to hire a research assistant, and it makes it possible to mail out, 2,500 surveys, which costs about $7,000 to do that. And so thank you for that support. You have no idea how much that helped me.
It is a pleasure, and given the important work that you're doing, so very small but important investment in the bigger picture. Your comments about like the lack of research and some of the reasons made me think about many minoritized identities and how in many scholarly or discipline or field spaces that pushes and innovation for new research or new lenses for research come from people from those minoritized communities. So everyone, this is everyone's responsibility to know about, and many people can participate in research and practice, but some of the perspectives that one might not think about in the field are pushed by people from the community. How do you think about dentistry as a space with regard to the representation and the action of people from the LGBTQ plus community? Has that made a difference? And is that also a direction that's needed to make a difference?
I'm a cis woman. I'm heterosexual. So I'm an ally. The LGBTQ plus community offers you that term ally. For many years, I was hesitant to publish, and I'm still hesitant to publish anything without some support from the LGBTQ plus community. And so for many years, I was kind of, what the heck do I know? And how can I do this? But I'm very passionate about it because you have friends, you have family members, and you want to do it for them.
Hopefully that spirit and that sense of allyship will be shared, and the idea that a part of allyship is engaging and connecting one's content to the community. So kind of your orientation toward connecting what you're doing and checking in with community members, I think is not only like the right thing to do, it's a part of a rigorous scholarly and practice approach. So just wanted to name like that allyship has responsibilities that relate to the integrity of the work, as well as the moral good of what and justice goals too. So and your work and your approach exemplifies that. Another set of questions relate to kind of you alluded to kind of the kind of political social context at towards the end of the talk, and there are a few questions that alluded to your view about kind of the current wave of legislation, such as Texas's legislation to ban puberty blockers, the Florida proposed legislation that's being coined "Don't Say Gay," but defining discussion of quote unquote alternative lifestyles as divisive or inappropriate context for schools. What is your what is your thinking about the implications of this? I mean, I guess I probably could guess, on with regard to impacts on transgender communities and oral health care and the issues that you discussed in your talk. And what do we need to be doing? You can speak for dentistry, you can speak for academia, or health, or thinking about health sciences. Like, what do we need to be doing to engage and advocate and push in the context of this wave of legislation or political movement?
As an educator, my students, when I every week I send a survey to this whole class has to answer a survey, and I always have one question: what do we need to change in the class? And from the beginning, people say, don't say anything political. Okay. So I try to stay in that, as an educator, that I get this warning from my students. Yeah, don't say anything political. And so at the beginning of the next class, I say I was warned again to say anything political. But here's a thought. When the term cultural humility came up as an opposite first to cultural competence, I was very intrigued, because this cultural humility basically assumes that we don't know that much about other cultures necessarily, but what we need to do is we should really advocate, and not just academically do something, but we should advocate and, you know, see how we can change things. I feel that cultural competence and humility go hand in hand. And so I would love that we as educators really reflect on this. So as a private person, I find what is going on very dangerous. For the persons who are either children who are LGBTQ plus or have parents who are LGBTQ plus. I watch the law situation very, very closely, because I have a son who graduated from Harvard and now works in the Trans Law Center in New York. And once a week we have an hour on Zoom where my son cannot tell me exactly what they do, but, you know, I can run by him all the law things that I heard about in a week, and we can discuss all of this. And, you know, I really hope that Lambda Legal, the Trans Law Center, PFLAG, everybody that is a nonprofit organization in this realm gets the money they need to do the best to make sure that they can do a good job in the laws to counter these attempts at really undermining the freedom of a whole group of people. That's my remark as a private person, and it shows you that I'm very interested in, you know, supporting legal organizations that try to do that. Interestingly enough, think about the fact that when they did that 4.4 million, this is a number that sticks in my mind, implicit bias tests. They found that the one thing that got worse over that decade they looked at was what? Obesity. It's now much more severely, negatively seen implicit bias-wise than before. Why? I bet you it has to do with the social media, with Twitter and with Facebook and with all of that stuff. Because what's around us makes a big impression on us, consciously and unconsciously. And my fear is that what's happening right now with these issues constantly being in the news and constantly being debated is a disaster for how people implicit and explicit wise see a group of people that, you know, that is singled out right now for political benefit of potentially getting votes from people so a certain political office can be obtained. That's enough politics.
Well, in the context of that, because I mean, as you said, that the things that shape behaviors and attitudes, like shape the types of practice that you're describing, you know, in the context of that real challenge, you know, and maybe, you know, as I look toward the end of this session, what keeps you going? What gives you optimism in the context of what feels very demoralizing and challenging, and, you know, often pushing back steps that have been moved forward? What keeps you going?
One thing I considering is when I do workshops alone, I get sometimes very offensive kind of responses. And so I'm considering these days if I could always do it with one other person, that might help me sustain continuing to give workshops. My research, there's no doubt that I'm very fascinated by it and I want to do it. And, and my educational efforts, well, I'm not giving up. I think about the fact that unless we are persistent and consistent and sure that we do the right thing, it's definitely not making us feel good about who we are.
Thank you. Thank you. And with that, I'm going to wrap up our session with a couple of comments. One is from your own dean and our soon-to-be new provost, Professor Lori McCauley, who says, "Congratulations, Marita. Your contributions are phenomenal and your lifelong work continues to be ahead of the curve. The School of Dentistry is a better place because of you."
Thank you, Lori.
And I will also share to you a final comment, which from audience member Sarah Bliss. "This is also wonderful. I'm so grateful for your work, Dr. Inglehart, and your leadership in educating our community about these important issues. Happy Trans Day of Visibility and Action to all." So what a timely and appropriate comment to end us on. I want to thank you again, Marita, for your discussion, this talk, the education and wisdom and commitment and heart that you've shown us today and throughout your career. And I would like to close the event by thanking everyone in attendance and also the team and members of the University Diversity and Social Transformation Selection Committee, the NCID team for all of their efforts. And to everyone, thank you for coming and enjoy the rest of your afternoon.